Hello, this is Dr. Jones in Tucson. Glad to be back. Hope you're all doing awesome and enjoying your summer. We're excited to share a few things with you today, and of course, feel free to share these videos and ideas with anyone who may benefit. Today we have a super topic for you, one we hope will provide helpful insight as you, your child, a friend, or someone you know is preparing for orthodontic treatment. I'll share several of the major considerations that arise during consultations. Parents and kids often ask questions about these topics. For that reason, we'll share feedback on these frequently asked topics to help you feel better prepared. In this video, I'll share considerations surrounding these topics. What role will my TMJ play? Do braces cause TMJ or TMD? What about tooth and jaw development and classification? How will crowding or spacing affect my treatment? What if my jaw is narrow or wide? What if I have a crossbite? What do these words, overbite, overjet, mean? So let's get right into it. We'll first focus on your joint. Your jaw joint is a long word. The name comes from two bones that interact or articulate to form this particular joint. The temporal bone on top and the mandible or lower jaw on bottom. These two bones form the temporomandibular or TM joint. We each have two TM joints, one on the right and another on the left. A disc, which pops or clicks in quite a few people, sits between the temporal bone above and the mandible below. Many people suffer from joint troubles. These joint challenges are gathered into one category that is referred to as temporomandibular disorders or TMD. Some people have many symptoms listed here. Other people only have a milder version of TMD and manifest only one or two symptoms. Common TMD findings include limited opening and limited movement, as well as locking of your jaw. Other findings relate to stiff, sore muscles surrounding your TM joint. Muscles may be especially sore while eating, or for others, the muscle pain is most acute when waking up in the morning. Headaches are also common in those with TMD. TMD frequently comes and goes, and it is more common in women. People between 20 and 40 years of age are most commonly affected. Mild TMD often starts in the teenage years, sometimes overlapping with the years Johnny is in braces. If you have severe TMD symptoms, we will advise waiting till those symptoms diminish before proceeding with treatment. In severe cases, we usually recommend visiting with an area dentist who specializes in helping with TMD. Please keep in mind, similar to shoulders or knees that have had years-long issues, TMD isn't something that can be cured. Instead, this joint specialist dentist will work closely with you to manage, not fix, your various joint-related challenges. Another point we'll cover in consultation is Johnny's tooth and jaw development. We'll check to see if Johnny has any baby teeth, also called primary or deciduous teeth. If he has only one or two, especially if those teeth are loose, we may suggest moving forward to start treatment. If he has several primary teeth and they're not loose, it's often not very efficient to start now. Best to put Johnny on recall to return in 6, 12, or some number of future months. Time to grow, lose teeth, and generally enjoy his life till it's more ideal to start what can be highly demanding treatment. Gotta brush, gotta floss, gotta avoid hard sticky foods for long periods of time. Not all 7-year-olds are ready for this level of commitment. Starting your child in braces with more than 1 or 2 baby teeth often results in treatment times that exceed 2 years. We hope to create a plan that is both effective, gets a great result, and efficient, occurs in 18 to 24 months, not 2.5, 3, or more years. Long treatment times are tied to kids and parents who are burned out emotionally, and Johnny has a higher risk of gum-related issues, white spots, or decalcification on teeth, and shortening of roots. Most of the time, if Johnny lacks baby teeth, we are ready to move forward. There is at least one situation where we will advise you at the consultation to wait, despite being 14, for example, and having all erupted permanent teeth. For example, if Johnny has a strong lower jaw or mandible, it is often best to wait to start treatment until after he finishes growing, to keep an option available for jaw surgery, something we will do after Johnny has stopped growing. Some boys don't stop growing till their early 20s. Surgery gives us the option to achieve an ideal result in cases like this where the jaw grows more than we prefer. Classification of your teeth helps us group certain arrangements of teeth together. Class 1 refers to the most ideal position of your teeth in the front to back dimension. Your teeth and jaws relate well to each other in Class 1. Your bite is good and teeth are interdigitated. You still may have crowding, spacing, and overbite, but at least your teeth fit on the sides. If your teeth and jaws are class 2, it means that, because of a variety of factors, you have one or both of the following. Your upper jaw is forward or your lower jaw is backward relative to ideal. If your teeth and jaws are class 3, it means that, because of a variety of factors, you have one or both of the following. Your upper jaw is backward or your lower jaw is forward relative to ideal. Another common point of discussion in consultations is about crowding or spacing. Mild crowding is resolved easily, often by widening the upper or lower arches, usually without an expander or surgery. If Johnny is severely crowded, we may need to remove teeth. The most common teeth we remove are premolars. First premolars, just behind your canine or eye teeth, are the most common ones to get removed. Spacing is common when teeth are small, and when Johnny has a tongue thrust. His tongue presses on his teeth when he swallows 1,000 to 2,000 times daily. It's usually fairly predictable to close spaces, but spaces often return after treatment unless you wear your retainers as directed. If you are missing teeth, we may not be able to simply close those spaces. Instead, you may wish to get dental implants, crowns, or other restorative work. We will discuss your options at the consult and collaborate with your dentist as needed. Most people don't have especially wide arches. Instead, most people have narrow arches into which normally sized teeth erupt. The regular series of wires will typically expand your arches to allow proper alignment. Crossbites, whether in the front or back, need to be corrected. Front crossbites affect aesthetics more and may cause recession on the lower teeth from consistent pushing forces. Back crossbites may affect your TM joint and can possibly lead to jaw asymmetries if not corrected. This is another topic that will arise during a consultation. Most people don't know this, that overbite actually refers to the vertical, not horizontal, overlap of teeth. If you have a significant overbite, that often means that you can't see your lower teeth because your upper teeth block them from view. If someone has significant overjet, that means a person has upper teeth that project far out beyond the lower teeth. Most orthodontists aren't going to correct you in the consultation if you mix up overjet and overbite. I thought we'd finish with a short quiz on overbite and overjet. Does this patient have an open bite, an underbite, small or large overjet, small or large overbite? Please share your guess in the comments below. We hope you enjoyed this topic. We have another video, click in the upper right corner, that discusses 5 more common topics covered in consultations. We'll review extra, missing, and impacted teeth, midlines and oral health, habits, such as mouth breathing, tongue thrusting, teeth grinding, sucking a thumb, other digit or object, and wisdom teeth. Thanks so much for watching. We hope you found this video useful and will share with others. Please comment below on a topic you wish we'd cover or with any personal experiences. Thanks and have a terrific summer.